everybody here to know what the intention is, which is very consistent. Those of you that know me with what I've kind of been preaching the gospel of my whole career, and that is to allow us to help people at home, to encourage people to be at home longer and avoid institutional placement. And so this is for duly eligible individuals. So they have Medicare and Medicaid. Who meet a nursing home level of care. So they qualify for a skilled nursing facility. And this is an alternative to skilled nursing, just like our waivers are. So our Medicaid waivered programs do the same thing, but there's a difference here. And the difference is this is a capitated program, okay, where the provider is, and the individual served, it is voluntary for them, as it is with Medicaid waivers. But it's a capitated program, and the provider takes all of the services, not just those community-based services, but everything that Medicaid member requires is provided for by that provider. These PACE programs like this are now in 32 states, by the way. So at any rate, I'm real excited about yet again another opportunity to keep people out of institutional settings and in the community. And I'm going to, with that, ask the department to come forward. Deputy Commissioner Thomas and Joe Hood, Chief Operating Officer of the department, to present to us on House Bill 1078. Thank you both for being here.
Good afternoon, Chairman Petrie and members of the committee. As the chairman has already stated, my name is Grant Thomas. I serve as Deputy Commissioner at the Georgia Department of Community Health. And with me today is Joe Hood, who serves as Chief Operating Officer. I first want to thank Chairman Petrie for his leadership for sponsoring House Bill 1078 and bringing the bill for consideration before this committee. We also greatly appreciate the opportunity to be here with you all today to discuss PACE. I know we had the opportunity to do that over the fall, and I appreciate Chairman Petrie for giving us that opportunity to provide an overview of PACE, the program overview, and how PACE looks nationally. As it stands today, Georgia does not have any PACE programs, as PACE is an optional Medicaid state plan service, which we have not elected into yet. However, in the FY 2024 Appropriations Act, there was budget language that instructed DCH to conduct a needs assessment on the establishment of one or more PACE programs in Georgia. So we conducted that needs assessment over the summer and fall of last year, and Joe will provide an overview of that needs assessment and the work we conducted on that last year. But first, I wanted to spend some time just going back. I know we provided this overview in the fall, just at a high level, explaining the key program components of PACE. Chairman Petrie did a good job of already giving some of that overview, but PACE is a federal and state program that provides comprehensive, integrated, and highly coordinated community-based care and services to adults 55 and older who meet state eligibility requirements and would otherwise reside in nursing home level of care. So as Chairman Petrie stated earlier, it allows these individuals to be served in a community-based setting. Individuals enrolled in PACE organizations receive all services that are covered by Medicare and Medicaid, as well as additional benefits directly from the PACE organization or through a contracted network of providers that the PACE organization engages. So the PACE providers doesn't have the in-house staff to provide those services. They can contract with providers. PACE participants receive services at the PACE Center and at their homes. The model uses interdisciplinary teams to assess and meet the care needs of participants. If other outside services are needed for the PACE participant, the organization must arrange for them and is financially responsible. Chairman Petrie mentioned this earlier as well, but PACE is unique in that the organizations receive a per member per month capitated payment from Medicare, Medicaid, and private pay sources, for which they assume all financial risk for all services, including long-term institutional care. Payments do not change based on the utilization patterns of the patient, And it's important to note that the beneficiaries who enroll in PACE agree to forego their usual sources of care and receive all their services through that interdisciplinary team in the PACE organization. Since DCH commenced work on this needs assessment, we have had at least 3 providers that we are aware of that have come to us and come forward expressing interest in serving as a PACE organization in the state. And organizations operate in service areas across the state. So there are designated services in which they provide care to individuals who qualify for the program and opt in within a geographic location and purview. So they have to demonstrate, the organization has to demonstrate a need in that community, and then if there is a need after a needs assessment, they can elect for services in that region. I did want to emphasize, like I said before, that the PACE provider assumes all risks for service costs, including hospitalizations and long-term skilled nursing, which is temporary or permanent nursing home. Therefore, what's really good is the provider's incentivized to do regular case management, chronic disease prevention and management, managing diabetes, blood pressure management, really looking out for that member to ensure that they stay healthy so that those long-term inpatient stays can be mitigated. The number of PACE programs per state really varies. For example, Tennessee is authorized for PACE programs. They only have 1 PACE program in the Chattanooga area. And then Pennsylvania has 19 PACE organizations, and those 19 organizations have 50 different PACE centers. There are 153 PACE organizations nationally operating in 32 states, as the chairman stated, and the District of Columbia. More than 300 PACE centers serve nearly 70,000 participants across the country. Most PACE recipients, as has been discussed before, are dual eligible for Medicare and Medicaid services, and approximately 90% of PACE enrollees are full benefit dually eligible beneficiaries. So this is a model that's recognized nationally and utilized in a majority of the states. Now I will turn it over to Joe Hood, who will provide an overview of the needs assessment that we conducted last fall, as well as our future implementation plans, as well as the details of the legislation in House Bill 1078.
Thanks, Grant. My name is Joe Hood, and I'm the Chief Operating Officer for the Georgia Department of Community Health. I wanted to echo Grant's comments and thank Chairman Petrie for bringing this bill and working with us to accommodate it here today. So I wanted to follow up on what Grant was speaking of and get into more detail. Specifically in the appropriations bill, we were asked to assess the viability of a PACE program and how that might be implemented in the state of Georgia. So in doing so, we looked at other examples and tried to learn, what is a PACE program from an operational standpoint. And I don't know how much of y'all know about that, but generally it is somewhere around a 10,000 square foot building that is going to serve with services within a geographical area. So a number of zip codes that's within a drivable distance of that building. And that's because the interdisciplinary teams will be based there, and it's based upon that you would do an assessment. So as Grant alluded to, it's a program of all-inclusive care for the elderly, hence the term PACE. So that building is all-inclusive for preventive care and checkups and assessments to make determinations on what is needed. To me, I think about it, I used to be a Kaiser member. I don't know if many of y'all are probably familiar with the Kaiser HMO model and how they do all care within one building. You can walk in, you can see a doctor, you can get an x-ray, you can get your prescription on the way out. That's sort of how I see this, except it's based around the elderly. In addition to that building, though, as Grant alluded, they have to have contracts for all services that are required. So hospitals, specialists, all the things. If you're familiar with Medicaid and our care management organizations, this is very similar to a care management organization, but it's much, much smaller, right? It's only the enrolled members for that geographical area that are getting that assessment, but they are at risk and they get paid on a calculated, capitated rate, as has been stated, that is calculated by an actuary. The state of Georgia has an actuary that does that for the care management organizations already that are out there that are under RFP today and under contract today for a large part of the Medicaid population. This would be no different in that we would be taking a fee-for-service population. That's a population that is in Medicaid today that is not in a CMO, and make them eligible for this type of program to deter them from going into a nursing home. If they go into a nursing home, most of y'all are aware that is very costly, because that skilled level of nursing is 24/7 nursing care. And it's just very costly to provide that in a room. Most of those end up being double rooms. If you're on a Medicaid basis, you're going to have a roommate and share, and just all the things to make those services as affordable as possible. So to defer that and keep them in community, we would be looking at this program. Now, we do have what's called a home and community-based services waiver. Many of y'all may be familiar with that for elderly programs, and it's similar in this concept in that you would provide services to someone in their home to deter them from going into a nursing home. The difference here is our home and community-based services are not at risk. They don't get a PM. We're still responsible for, at the state, for all the bills on a cash basis that come through for that person. So when we go to a PACE model, that's the big difference, is that that entity is going to be responsible. Now, from a state perspective, and have a financial background primarily, the advantage for the state is this is a Medicare established program, and it's targeted at the Medicare duly eligible Medicare and Medicaid participants who are on our fee for service. But Medicare will pay a large percentage, I would say almost half, of what the PM calculated rate is for those members who enter. And then those members who enter, they're in that program for the duration of their life, unless that program ceases to exist and that provider goes out of business, or and even then they could be absorbed potentially into another PACE program if there's one nearby. But without that circumstances, they're in that for life. So if they end up progressing, going to the hospital, as Grant talked about, going to a nursing home, we are essentially then splitting costs with Medicare on that PM to pay for that. Absent this program as we have it today, home community-based services, for example, they go to the hospital, we got to pay that full cost out of Medicaid at our FMAP percentage rate, which is, about 3-to-1, is 67% or so. That's federally covered there. So that's the big difference on this. So there's a big incentive on the provider to keep them out of the hospital, to keep them out of the nursing home, because that keeps those costs low. We don't really have case management for this population today. They are really up on their own to manage themselves. And that's the huge difference. That's what CMOs will tell you is the big advantage, that they're going to manage that case, provide social services, preventive care to maintain. So that's really what we're trying to accomplish that here in a community. So as part of our assessment, we had a number of providers that came forward and said they were interested in this, and they were primarily in metro areas. So we reached out to the National PACE program, which is an association of all the programs within the country that Grant alluded to earlier, and we asked them for assistance. And what they came back with was a free service where they went out and they did a formula that they have perfected to estimate how many participants would be in each zip code that we were targeting, to see if we would have viable geographical areas that a PACE provider could go in and operate and have sufficient revenue to operate a program. So they wouldn't do the whole state, or that would be egregious for us to ask that. They said, do you have targeted areas where you think that you would have providers that you want to look at? So we chose Bibb County, Chatham County, and Fulton and DeKalb County, because that's where we had the most interest. And Fulton and DeKalb obviously is the largest population center for us in a metro area. So those are the counties that we chose and where we thought that we would have population. They did a zip code search, and from those combined counties, they had over 30,000 folks that they think, from population census data that they put through their formula. What they do is they look at the income that's in the census data, the population, the age, the disability of those folks as reported in the census, and they combine that into this formula that they've developed and proven effectively with other programs in other states that will demonstrate how many folks in there are eligible for a PACE program. So in doing that, it showed that each of those counties had a viable population to their understanding. So for example, Bibb County, they estimated it had 1,656 potential eligible candidates in the zip codes, where all the way up to Fulton County, which has over 22,000 eligible folks for that particular zip code. So what we would expect from that assessment, given the PACE consultation that we have, is you might have one or two in some of the smaller areas, but you might have as many as 10 potential eligible ones in Fulton and DeKalb in a metro area because of that population size that's there. That's generally the concept of what we've looked at. After that point in time, we had discussions with each of those providers to assess their operational readiness and to look at when they might be prepared. And we got assertions from each of them that they would be prepared to go forward very soon. Some of them have real estate available today that they already own that they think is adequate for a PACE facility, and already have staff in place given other designs in nursing homes and home health lines of business that they think would allow them to immediately move into a PACE certification. So with that, we went out and we also sought assistance from our actuary. So we have an actuary with the state, as I mentioned, for the CMOs. That's with Deloitte, is our actuary for the state at the Department of Community Health. And we've asked them to incorporate this and to begin to develop a rate, a PM rate that we would be able to utilize on the conclusion of successful legislation that we have authority to set it, that we would then use. In addition to that, we've sought out consultation from one of our primary vendors, Myers and Stauffer. They're a CPA firm that specializes in Medicaid. We have them for a number of contracts for fraud, waste, and abuse and other matters at the department. And within their contract, we would utilize them to do operational readiness assessments and to do what's known as a request for qualified contractors. They call it an RFQC. Some of you may be familiar at the Department of Administrative Services. And the concept there would be that they would put into play in a request for qualified contractors all the Centers for Medicaid and Medicare requirements, all the Medicare requirements, and then we would put that out to bid, essentially to recognize who is qualified to proceed in the targeted zip codes that we would have. Upon completion of that, we would continue with Myers to do operational readiness of each of those providers to certify, and then they would have to go to CMS and get approval on an individual basis to be a provider with those provisions that I've referenced. Once they've received CMS approval and approval from the department, then they would be able to move forward as a provider. And what that really means is that they have an operational building, a 10,000 square foot building generally, with staff and accompanying contracts that would be similar to a CMO to begin operations for those residents or patients that they would be seeing. That's really our plan as it stands. We think it would be a great benefit. It does coincide, I'll reference, with our request for proposal for CMOs that's out there today. And when that would go forward, we think it would be at a similar time frame in place as when we will be awarding new contracts, which would work nicely, as some of these members are projected to be in that RFP. They're stated as populations in that RFP today. So that's generally the plan. Happy to answer any questions that you may have, and would seek your favorable consideration.
Okay, thank you to both of you. Excellent summary of what we have here, and I appreciate both your leadership in this matter and everything else I've dealt with you on. I appreciate you so much. That was a great. I have one quick question, and we have several here. The 30,000 folks that are available in those three areas, and I did want to ask you, Mr. Hood, about the Chatham numbers. Would be interesting to me too, and I can get that offline later. But those are individuals that are likely could benefit from this. Are those folks that are likely not on waivers currently on one of the other waivered programs, or you can't really know that, can you? Gotcha. Okay. Gotcha. Thank you. All right. Let's see. Yeah. Okay. I think we got 21 first. Yeah. Representative Cameron.
Thank you. I think I may have said this in our hearing in the fall, but I live 2 doors from the Tennessee border, so I'm familiar with Lexington Brothers Senior Neighbors Program. It's an excellent program. They were gearing up at the time, at the end of my mother's life, and that would have been a great supplement for me as a caregiver to have that program. It's an excellent program, and it will benefit a lot of people. And it will also, you're exactly right, it will keep a lot of folks home where they want to be at the end of their lives. And so thank you very much for this. Thank you.
Next. Gamble. Let's see, 27. Representative Gamble.
Thank you, Chairman. I appreciate this legislation. I appreciate the explanation. I missed our hearing back in the fall, and I apologize for that. I am just curious for just, let's say, the individual that's 68 and Medicare, that without this program, they're either going to not receive the services that they may need, which could be problematic, or they could be in just a traditional nursing home type facility, which is probably more than they may need. Is that a fair assessment of what's happening right now without this? Or tell me what happens if this doesn't pass. What does the scenario look like for the individual, like what I explained?
Yes, sir. So they have to meet a skilled nursing level of care.
Okay.
So we are talking about a population that is eligible for a nursing home today to
Okay.
enter into the program. The difference being they would just receive those services in the home. Even though, but there, to your point, there are a great many differences on the acuity span of who is eligible to be in a nursing home. I mean, there's folks in a nursing home who probably they just have some need, some disability that qualifies for them there. They may be on the low acute, have not need as much. And then there may be dementia patients, right? So there's the whole spectrum of who's in a nursing home. So certainly you're talking about most likely someone who is still somewhat independent, or they have caregivers in the home and can be cared for in a home and don't want to go to a nursing home. That type of person. Without this program today, they would either be left to caregivers at home within their home, and if they qualify for Medicaid, they could get additional services perhaps through a waiver, through home community-based service waiver. So this would very much be similar to an HCBS waiver in how the services would react. The difference really is for the state, there is no Medicare savings or cost sharing is how I should put it for the HCBS waiver. So that's really the big difference on that. Now, I also do think that PACE provides an additional benefit because the home community-based services folks don't get the same level of case management as you're going to get here. This requires, per Medicare regulations, an IDT team, interdisciplinary team that Grant referenced earlier, that has to do regular assessments, referrals, a lot more preventative care, it appears to me, than an HCBS might provide, because they're trying to defer you going into a nursing home or into a hospitalization. But those would be your two options, the home community-based service or nursing care.
Okay, thank you.
I'm going to add one thing to that, Representative Gamble, just to make sure everybody's clear. So these individuals are already on Medicaid. They're on Medicare and Medicaid. So right now, because they meet a skilled nursing home level of care, remember, nursing homes are an entitlement in this state and every other state that I'm aware of. So those individuals are entitled to go to a nursing home, which is the most expensive way to serve people. The more institutional, the more expensive. And so this allows them a cheaper, for taxpayers, opportunity, cheaper for the state, especially with the Medicare covering half of it, but a cheaper route, a more efficient way of serving people at home rather than them be institutionalized prematurely by just taking the institutional route. But if that helps. All right, Representative Campbell.
Thank you, Chairman, and thank you for this presentation. Looks like that provides a lot of possible positives to comprehensive health care for eligible seniors. I have a couple of questions. So the first one is related to the part of the legislation that is asking for exemption from the regulation of requiring authority of being an HMO. We talked a little bit about this, but I'd like to, for the purposes of the committee, understand that further.
Yes. So generally, we don't want to create new regulations for program of all-inclusive care for the elderly that is beyond the Medicare regulation. We want to rely upon the Medicare regulation. And remember, we have to get, I don't think I clearly referenced this, but we also as a state have to present to CMS our plan for adoption and implementation of this, and first get CMS to agree in our Medicaid plan that they're going to allow us to proceed. And the simplest way for us to do that is to simply say, we're going to adopt your regulations in our administrative procedures to proceed without anything additional. There are provisions in an HMO that potentially would conflict. I mean, we want to rely upon the Medicare standards. That's what we're trying to do here. My understanding is this is based upon Texas legislation that was passed that was similar when they adopted PACE from our general counsel when they looked at it. There are other states that have implemented differently. So I don't want to mislead the committee that there isn't other ways to do this. Some have gone a licensure route and had them be licensed as something else. We're really trying to find the most efficient and expedient way to get them there without that. And we see many states that don't have a licensure and don't require that and just rely upon Medicare. And we believe that's the most efficient way to proceed as a state for us, both for CMS approval and for the providers that would be applying.
Okay. Which makes sense that maybe there would be some duplicity there, but also you referenced numerous times, if I was understanding, it functions very much like an HMO or a managed care organization. So I guess I am curious to understand then if there are any major issues that would be either more or less costly for taxpayers and or more or less restrictive for patients in care, being regulated as an HMO versus being regulated by CMS.
Well, I think there would be more restrictions here. They'd be subject to whatever state regulations are affiliated with an HMO. They'd be subject to statutory changes that would occur. I mean, in the future, all those things that potentially would be impediments and would put us at risk with CMS if any of those differ with federal regulations.
Okay. And if the chair will allow, I have two other quick questions here. I think they'll be quick. One, just to confirm, I thought you had shared once a patient opts into this program, they can never opt out, meaning they don't like this policy, this practice. What happens if?
I don't know that that's true, but the thought is that they would retain into the program. And I do believe they would have the ability to come out if need be. I would have, let me follow up on that question specifically because I don't want to misspeak, but that's off the cuff. That's my understanding is that they would still have choice.
So they would have choice potentially, but we'll need to confirm to go
Right.
back into traditional Medicaid.
Right.
Okay. And then can you sign up if you are not dually eligible and or pay out of pocket for any of these services?
I need to follow up on that because you're speaking a non-Medicaid person, someone, for example, who's on Medicare only, perhaps. And I don't know the answer to that offhand. I'll have to get back to you on that. Now, for the Medicaid population, we've been speaking of Medicare, Medicaid, a dually eligible. We would have Medicaid only that we would also allow to enroll that's in fee for service. It just means that we would be paying the full share of the PMPM for that, but it would still be a benefit to the state because we'd be putting that member in a managed care plan and they would be at risk with the provider. So it would be anyone who elects to do that out of the Medicaid population who meets the criteria for PACE.
Very good.
Just one more if the chair will allow. And I appreciate it. There's a lot, a depth, I think, in this program to truly understand. And is it also accurate to say that participants in this program will also need to make sure that they fully understand the estate recovery program once the patient dies and or any implications for their spouse or children related to real estate recovery, losing their homes?
So that would have to do with only the Medicaid clients. So that, that's true regardless of this program. If they are on Medicaid, they are subject to estate recovery today.
Correct.
So if they are able to opt in and not be on Medicaid, that would be most likely a private arrangement between the provider and that Medicare individual. And I don't believe I don't believe we would be involved as the Medicaid entity. That's really why I need to follow up on that and see how that might operate.
Okay, thank you.
Representative Cannon.
Thank you, Mr. Chair. Just a question about the fact sheet that we received. It speaks to helping informal caregivers, as well as a number of other individuals. I'm just trying to see how are informal caregivers helped in the process of initiating a PACE program.
So Grant and I apologize. We're not familiar with what you're
Yeah,
referencing.
that's not your document. I don't think that,
Okay.
Anna, where did?
We didn't
this
have a
document
handout
come
for
from?
this particular.
This is
committee
probably from, is it from, okay, it's from Savannah Hospice. Okay. So that's for, and actually, so Representative, they're going to speak remotely in a moment. We'll save that question for them. Representative Bruce.
To what extent because this stuff is complicated, you know, and people make a wrong decision. From what I understand, to her point, once you sign up, you signed up and you can't get out unless there's something that happens. Like if you're on your spouse's program and the spouse dies, then you have an option to make a change.
Well,
That's
let
my
me-
understanding. But let me ask the question that I want to ask. her.
Okay.
To what extent do you guys educate, you know, people who are state employees that are about to retire so that they understand all of this stuff? Is there anything that you guys do to make
So
sure?
this is entirely different because this is a Medicaid program, Medicaid program only. What you would be referencing is our state health benefit plan, which the department does run effectively for retirees, but that's a different program. And we do, to answer your question, on that particular note, we have education sessions throughout by our SHPP team that's fairly effective. And then they have further educational sessions when that retiree nears the Medicare age because of the Medicare Advantage plans and the requirement to enroll in Medicare. But that's separate and apart from what we're discussing today.
Representative Bazemore.
Thank you, Mr. Chair. Thank you for your presentation. I just had two quick questions, hopefully. You mentioned that there are providers that, I'm right here. Right here.
I'm sorry. Thank you. I apologize.
All this pink on. Who are the providers that you were indicating that wanted to be a part? Because you mentioned it several times. Do we know who those providers are?
I think probably almost all those providers are on the agenda to speak, but I don't mind naming them. I think it's Pruitt
Okay.
Healthcare is one that had inquired with us, Kinship, and then there is Savannah Hospice. Those are the three that I'm aware of that have inquired and that we've worked with or had conversations with.
Okay. And if I can, Mr. Chair, how would, if at all, this new program would negatively affect the current way everything's done?
I don't believe there is a negative impact. I did want to qualify a little bit to explain the state elects how they manage the population. So for example, if you are on Medicaid today, the only choice you get is which care management organization you want to be in. You don't get to elect beyond that. And this would be no different in that respect. You're going to have to pick if there is a choice there. And that's, I need to look on that if you can come out of it. Certainly are electing to go into it, but it's really, there's not much choice because you are receiving an entitled program that's 100% covered cost. But with that being said, I really don't know a negative impact to the program. It really is all positives in my respects because it provides case management, provides preventive care, provides an incentive to that provider to do all those things to keep their costs low, to be within the monthly rate that they're getting reimbursed. I can't really think of a negative on that. I do want to explain though, and Grant mentioned this earlier, there's a number of states that have this, but the size of those programs is pretty small. So I don't want to give anyone the impression that this is really competition even for a care management organization that is going to serve hundreds of thousands of people. These providers are maybe going to serve like 1,000 folks per site, something like that. We may get up to 10 sites. You may serve 10,000 people with those 10 sites as compared to our, over 2.3 million at this point in time, or somewhere 2.5 million, depends on what point in time we're at, but large Medicaid population. So it's really a microcosm of what the larger population is.
I just want to say,
Oh,
sorry,
yeah.
go
I
ahead.
was just going to say to Joe's point, it is a very small program within
Mhm.
Medicaid. I think I said in my remarks earlier, there are about 70,000 participants nationwide. And to put that in perspective, there are about 71 million people in Medicaid
Mhm.
right before the pandemic. So that just gives you kind of an idea of the group we're looking at here. And it's, as Joe said, it's completely optional for them.
I just want to say thank you because my kids already told me they're putting me in a nursing home. And so now I can stay at home.
That is not nice. We're going to have to talk to them about that. All right, Chairman, Representative Cameron has a point he wants to make.
Thank you. Thank you, Mr. Chairman. I just looked up some on the PACE program on CMS's website. It says you have a right to leave the program. If for any reason you do not feel the PACE program is what you want, you have the right to leave the program at any time and have such disenrollment be effective the first day of the month following the date that you notify them and receive participants notice of voluntary disenrollment. Just want to make that point.
Yeah, so thank you so much. And I just wanted to clarify. So if that were to occur and that being the case, it would depend upon what level of care you needed. If your option would be to go back to fee for service. If that population is still in fee for service, a number of these are going to be in CMOs most likely in the new contract. So it's just going to depend on where the population lands. So I would likely say you would be in a care management organization probably in the near future.
Could you re-enroll if you disenroll in the future? I guess that's the point. I can't find that.
I would think so, but I wouldn't. I don't know if that provide. It depends on certain factors. I don't know the answer to that though.
All right, very good. If there are no more questions, we do have a couple of providers. I think we have two providers that were alluded to that are going to speak. They're going to come in remotely. Thank you to both of you. And again, thank you for helping us to continue to find new ways of taking care of the most vulnerable people in society on Medicaid. That's very important. We continue to be innovative to that end. And I appreciate you here. Let's do this. And you guys, I think y'all can hang tight there. Maybe
Okay.
if you're comfortable.
Yes, sir.
Because we're going to do this remotely if Anna can help me. And we have Kathleen Benton first with Savannah Hospice. It's at Chatham County, those Chatham County numbers you mentioned, Mr. Hood. And so hopefully we will get her up right now. Dr. Benton, you're on.
I'm here. Thank you so much. And my apologies. I did try to journey up I-16 today, but had some car trouble and had to go back and be virtual. So I apologize for not being present with you. I'm hoping everyone can hear me well.
One second.
I represent.
Hold on, Kathleen. We can't hear you.
Oh.
Give us one moment.
Okay.
Can you say something, Kathleen? Let's see if we've got
I'm
you.
here.
Nope,
Can you hear
not
me?
yet.
Not muted.
Oh. Try that, Kathleen?
Can you hear me now?
Nope. She can hear us though quite well. We
Mhm.
can't hear you, Kathleen. Hold on one moment.
Okay. Oh, I got it muted.
Okay, Kathleen, let's try one last time.
Can you hear me?
Yes.
Oh, yay.
We got you.
That's
All right.
Great news.
This,
Okay.
So Kathleen Benton, CEO of Savannah Hospice,
That's right.
all
And
yours.
I was just apologizing first to let you know I did try to journey up I-16, but had car trouble and had to go backwards today. So I wanted to be there with you, but I thank you, and I am representing Hospice Savannah, which is a potential provider of PACE. We are a 45-year-old nonprofit organization, community-based, that does serve Chatham and surrounding coastal counties, and probably can answer a couple of the questions that have already been posed about PACE, because I've actually been researching PACE across the United States for the last 2 years. So I've visited many of the sites, and I will speak to, I believe it was Representative Campbell's question about whether or not just Medicare but not Medicaid could be a part of PACE. There is a small percentage in many of the states where they allow Medicare only, and then they private pay the remainder amount. So it is open to others outside of the Medicaid. I thought it might be best today, because PACE is so complicated, and all of these programs really are difficult to understand unless you're in the community-based space, to tell a quick story, a couple of minutes, about a patient named Mary. Mary is an 85-year-old patient who is being taken care of by her family, has early onset Alzheimer's, COPD, chronic obstructive pulmonary disease, and congestive heart failure. Mary's son and daughter trying diligently to keep her home, as they always said they would, keep her in her own 45-year-old home. She'd been there for so long and committed to staying. And what that meant in the last year was that they experienced 7 hospitalizations with Mary, different issues, infections, falls, some breaks, some wound issues, and even 3 emergency room visits from shortness of breath, both with issues with the oxygen and issues with retaining fluid from the congestive heart failure. Meanwhile, her son and daughter are very, very exhausted. The son is even developing his own medical conditions as a result of being what is termed an informal caregiver from that fact sheet that we provided you, which actually comes from the National PACE site. Informal caregivers are those that are unpaid and doing all of this alongside their jobs, alongside of taking care of their own children and households. And every day, the son and daughter are rotating, coming to Mary's house and getting her up, helping her bathe. Then one comes during lunch. If paid caregivers cannot get to the home, much of the time they fall short and are unable to come. We have a huge shortage right now with paid caregivers. So it becomes the informal caregiver, the family, the friend, or the neighbor, in this case, the son and daughter, that step in and have to do that. And then one of the son or the daughter are there at night to make sure that Mary gets dinner and gets to bed. She has neurologist appointments, cardiologist appointments, pulmonology appointments. She has primary care, along with all of the hospitalizations. She's in her home as much as she can be, unless the son and daughter are transporting her to all these many visits, or unless she's in the hospital, or twice was in a nursing home facility in 1 year for rehabilitation because of those falls. So that's the year that Mary experienced with her son and daughter. And as the elderly population is the fastest growing segment of all the populations in the nation and in Georgia, this is a common experience for a lot of people right now. So the question is, what would be the difference if Mary had PACE? So with PACE, home caregivers would come every morning and get Mary up. they would put her on a vehicle owned by the PACE and transport her to that building structure, the 10,000 square foot that Joe spoke about. And that would not be a day center, but rather a clinic. So yes, it would have socialization and entertainment, psychosocial support and counseling for Mary. But at the same time, if Mary needed to receive fluids, there would be an infusion center there, physical therapy, occupational therapy, speech. There would be a dentist. Mary could even get her hair done while she was at a PACE site. These sites are absolutely amazing and they are all over our country. I've been to many of them, from Charleston into Tennessee, Florida. All of our neighboring states right now have PACE, and they really are brilliant facilities. Likewise, when Mary needed to go to the neurologist or the cardiologist, she could keep those same physicians, but it would be the PACE that would transport her with an advocate to those different specialists, and they would be there for her doctor's appointments. And then that interdisciplinary team that Joe spoke about would review Mary's case every single week to make sure that they have all the notes from all the specialists and they know what's going on with Mary's therapy. At night, the PACE would transport her home and help working alongside the family to get her into bed. There would be weekend help. Pretty much every need that Mary had, even if she called at 4 a.m. with shortness of breath, we'd be met with an after-hours team that would come to her house or meet her in the emergency room. And what that helps with, even if she is hospitalized, is to make sure that she does not have a long stay. She may just need symptom management briefly in the emergency room, and everything else can be done with the team at home and with her next clinic visit the next morning. So it truly saves those redundancies in care and thereby the resources. At least 12% per patient is saved with these PACE organizations. And more than that, it takes all of the disjointed care and the burden that comes to caregivers and gives them huge, huge help. Of course, as was stated earlier, if Mary decided she didn't like the program, she could disenroll at the end of the month, and yes, could certainly re-enroll as well. PACE has been around and proven successful for over 30 years across our country in many of the states. And as I've been able to witness this, doing my own research for potential provider in the counties that I'm in and surrounding me, I have seen it in total agreement and appreciation for the work that Joe and Grant have done to say that it's hard to see any downside to this program. It is very unique, very disruptive, and truly embraces the full patient care. Like I said, from dentistry to the hair salon, to the neurologist, to transportation. So I didn't want to take too much of your time because I do think that the chairman introduced this beautifully, and I'm appreciative to him for lifting up this bill, and DCH explained it for all the details. But I also am available for questions as well, because like I said, have been very vested in it for a number of years for Georgia.
Thank you so much. We appreciate you coming on like this. We have one other. We're going to now, thank you, Dr. Benton. We're going to move to kinship. Oh, we have a question. Who is that? Representative Byrd. We have one question. Kathleen, oh, 1 second. Representative Byrd.
Thank you very much, Mr. Chairman. I think it's kind of a general question. We, as the state of Georgia right now, can barely get anybody to work. We're always talking about workforce development. If we start a new program such as PACE, how are we planning to get people to work this program? That's my first question. Other things that have come to mind, we expanded hospice, if I remember correctly. Why can't we expand hospice to maybe take on some of that, as well as senior centers? I know that there's a lot of senior centers across the state of Georgia, and that would be another way, an avenue to expand. So thank you.
Yeah, thank you, Representative Burden. And Kathleen, you can take those if you'd like. What I would say, so the senior centers, of course, are not providers of all the different aspects of healthcare. They're just doing a senior center. But is there, Dr. Benton, would you like to address that?
Yeah, and I think what you said about expanding hospice is a brilliant point, and this is actually a way to expand hospice, in fact, because in talking about your caregiver question, I think the importance of utilizing a provider that is already in the site. I, of course, have 200 caregivers who work for me already. So it would not be difficult for me to recruit those right now. Being community-based, I do not have a lot of trouble with staffing, and I think it's different everywhere, so I can't speak to all providers, but we're in a very unique field, so possibly that's the difference. I will say PACE across the continuum does an excellent job of staffing. And I think a lot of that is because you're talking about a lot of unique staff needs. A nurse, for example, manages about 60 patients because of the way the model is set up. A lot of the care is done by therapists. So I just recently hired a full-time occupational therapist. That is not as difficult as far as staffing goes right now. And then the informal caregivers are also achievable through collaboration. A senior center is actually one I'm collaborating with to look to be able to lift up a site in the future. So I think the goal of collaboration and PACE is the best way to make this a success. And then utilizing providers that exist in the community who have already lifted up staffing instead of starting from scratch is great as well.
Thank you very much. All right, one very quick last question. Representative Campbell, is that you there? Very quick. We got to get to our last speaker and then we'll take a motion. Okay.
Thank you, Chairman. And thank you so much for all that information and the story about, the personal way this could come to life and help our families. One thing that you mentioned, and I just want to clarify, in the process of transportation to doctors, I think I heard you say they can see all of their same providers and doctors. And for me, that is a question. If you opt into this program, I guess I understood that there would be a system of doctors that would be a part of the PACE program. You would not necessarily keep all of the doctors that you might have had before opting into this program. Could you clarify that a little bit? And then also,
yes,
just Chairman, sorry, but I have some constituents who are interested in watching this, and I don't believe this hearing is online right now. If you could help us investigate that.
So the PACE does transport the patient to different doctors. That's correct. And it's not the PACE doctors that are the specialist, it's their network. So as long as they're in network and across the board, PACE pays the Medicare rate. So most of the time it is not difficult to add those doctors to the network when requested by the patient. That can't always happen, so I can't speak about that universally, but it is absolutely available to not just have a PACE neurologist, but a couple in network, depending on the needs or the choice of that patient. Just like an insurance network would do. They build their own, so they're not their doctors. The doctors are the primary care physicians, usually that gerontologist, maybe a palliative physician, they would be employed. And then the specialist would be outside and that they would transport them there.
Thank you, Dr. Benton. And that is all our questions. Thank you so much for being with us. Representative Campbell, you are correct. Apparently it's not showing live. It will be archived and available, but there's some technical reason they tell us it is not live at the moment. I was not aware of that. Thank you for making us aware. Thank you very much. We're now going to go to Miss Judy Cohn of Kinship Health, which as I understand it, Mr. Hood is interested in the Fulton DeKalb project. Okay.
So good afternoon, and having the distinction of being the last speaker. Dr. Benton, you did a great job in presenting PACE. I was going to read from my testimony, but I think the most important thing when you think about PACE is it is uniquely person-centered. Every individual has a plan of care that is customized to meet their needs, and that includes their psychosocial, their medical, their home situation, their ability to bathe, their food preferences. It is a virtual nursing home without walls where every participant becomes a unique member with their own cultural preferences and unique needs that are met by the PACE program. With that, I just want to introduce myself. I'm Judy Cohn. I'm the Chief Strategy Officer for Kinship Health, and I'm proud and delighted to provide testimony in support of the PACE program. We at Kinship are enthusiastic about the prospect of the state of Georgia considering implementing a program of all-inclusive care, otherwise known as PACE. This innovative program is specifically designed to coordinate and provide essential care to the frailest senior members of our community as an alternative to nursing home placement to help them maintain their safety and well-being in the community and avoid the unnecessary admissions to long-term care nursing facilities that isolate them from their loved ones and from their community. Kinship Health was founded with a singular purpose to operate PACE programs in unserved areas of the country. Our leadership team is comprised of individuals with extensive experience from CenterLight Healthcare in New York, one of the largest PACE providers in the country. Our collective mission is centered around empowering seniors, particularly frail elderly, to lead dignified lives of the highest quality within their community. With a participant base of over 6,000 PACE participants operating out of 11 PACE centers across 7 counties in New York, CenterLight is recognized as one of the most culturally diverse and prominent PACE providers in the United States, proudly serving their communities for over 27 years. Kinship Health is also actively engaged in developing PACE programs in a number of states, including Illinois, Florida, Kentucky, Arkansas, and Indiana. Kinship stands firmly in support of developing PACE programs here in Georgia. The PACE care model is renowned for its effectiveness, innovation, personalized program, accessibility, and value, which offers the highest level of independence for seniors with significant healthcare needs. Our holistic approach, tailored to meet participant healthcare and wellness requirements in both social and medical contexts, as determined by the interdisciplinary team, are unique and instrumental in enabling seniors to age gracefully in familiar surroundings of their homes. I will reiterate in terms of state advantages, on average, states recognize a savings of over 12% for long-term care as an alternative to where these individuals otherwise would have been served in institutional settings or in unmanaged environments where home and community-based services are not well coordinated. In closing, I'd like to express our eagerness to collaborate with the state and to pass along the benefits of the PACE program to Georgia residents. Thank you again for your time and the opportunity to present Kinship's support.
Thank you so much, Ms. Cohn. We appreciate you being here today. We appreciate your interest in serving frail, vulnerable Georgians. Thank you for being here. All right. Well, I think we've heard plenty of testimony. We've had a lot of good questions. I don't see any more questions. So, what is the will of the body?
Move to pass.
Got a move? Got a second? All in favor? Any discussion first, I guess I should ask? Any discussion?
Yes.
Mhm.
Is the size of the PACE community, does it got to be a certain population? Anything like that?
Well, so here's what I would say. The department has honed in on areas or regions where they have enough population to provide a viable location. But is that what you're speaking to? Yeah. My understanding from the department is there's these 3 initial projects, which would be Chatham County, Bibb County, not too far from you, and then Fulton DeKalb, but ultimately could well be numerous sites based on the experience and the success in any number of areas where there's a population that needs to be served. Yes, sir. Yes, sir. No. Any other discussion? All right. We have a move to pass. We have a second. All in favor? Anybody opposed? That's wonderful. It's unanimous. Okay. Thank you. Thank you. Thank you all for being here. That's quite all right. We were all scrambling to get here. I ran here myself. No worries. You were quite all right. Thank you. And thank you to the department for all you're doing. Thanks for all your help.